Let me ask you something. What is the evidence for evidence? How do we know which type of medical knowledge is best in each situation? And how do we invite medical students to always remain critical of the way they integrate medical knowledge with medical expertise? My name is Mario Veen. I'm the action editor of the Philosophy in Medical Education series of the journal Teaching and Learning in Medicine. In the previous episode, we discussed the relationship between teaching and learning in the context of philosophy of education. So I think it makes sense that in this episode we will discuss philosophy of science, and to be precise, epistemology and evidence-based medicine. We will discuss the article Teaching Medical Epistemology within an evidence-based medical curriculum, with the authors Mark Tonelli and Robyn Bluhm. My co-host for this episode is Nabila Mayat, and you can find the article in the description. Well, we're in 4 different time zones at the moment. Robyn is in Michigan, Mark in Seattle, Nabila in the UK, and I am in the Netherlands. Let me introduce our guests. Robyn Bluhm is an associate professor in the Department of Philosophy at Lyman Briggs College at Michigan State University. Her research examines the relationship between epistemological and ethical issues in medicine and neuroscience. She is a co-editor of the Bloomsbury Companion to Philosophy of Psychiatry and of the International Journal of Feminist Approaches to Bioethics. So, Robyn, we're going to speak about the branch of philosophy called epistemology. But what is epistemology, and why does it have your particular interest?
So first of all, epistemology is from the Greek for theory of knowledge or study of knowledge. I actually became interested in epistemology and more specifically philosophy of science because as an undergraduate, I was a science student. My first undergraduate degree was in neuroscience, and I found that I was more interested in questions about how scientists get knowledge and use knowledge and what counts as a good theory or good evidence than I was in actually learning about how the brain works. I was interested in that too, but I realized that the things that really interest me are questions about how to look at how scientific theories are built or how scientists adjudicate disagreements between them about the evidence. Later on, I became more interested in that in the context of medicine, which makes things even more complicated because the stakes are higher.
So scientists are interested in how the world works, and you're interested in how scientists figure out how the world works. Is that right?
I think that's right, yeah. And I would like to think that philosophers actually do have a contribution to make to this as well, that we tend to be very good at picking out situations where scientists might be talking past each other or using words in ways that are not always concrete or not always consistent with other things that they do. I found that I was really interested in reading about science and thinking about it more than I was in actually doing it in the lab.
You wrote this article together with Mark Tonelli. Mark Tonelli is professor of medicine and adjunct professor of bioethics and humanities in the School of Medicine at the University of Washington in Seattle. He works as a critical care physician, and his scholarship focuses on clinical decision-making, particularly the epistemic pluralism required for case-based reasoning. So, Mark, what is that epistemic pluralism?
So, as Robyn said, epistemology is about knowledge, and epistemic pluralism says, particularly in medicine, that there are a lot of different kinds of knowledge that clinicians should be using in making medical decisions. And that's an area that became a specific area of interest for me back when evidence-based medicine was introduced, about the time when I was finishing my own medical training and fellowship. In that, the reliance on published clinical research, while it had many advantages, also seemed to devalue other types of medical knowledge that seemed to be very important for clinical decision making, medical knowledge that came from our understanding of pathophysiology, or that kind of medical knowledge that you gain from taking care of patients. And that experiential knowledge seemed to be devalued. And so I became very interested in thinking about that in a more formal sense. And part of what we'll talk about, how can we teach clinicians to value and incorporate different kinds of medical knowledge and understand the strengths and weaknesses of different kinds of medical knowledge when it comes to taking care of patients. And as a professor in a medical school, I interact with medical students and residents and fellows on a regular basis. And so this is an important question for me in my daily activity as well.
And how does it feature in your daily activity?
Well, one of the interesting things that your audience of medical educators will recognize is that when you're a clinician and practicing in a training environment and attending in a training environment, is that you have to get used to smart people asking you very hard questions every single day, and that every one of your clinical decisions is subject to review. And so it becomes very important to be able to explain why you're making such decisions. That is, I think the best clinicians, the people we value for their clinical reasoning skills, ought to be able to make that explicit and be able to tell you how they're reaching the conclusions that they're reaching. And that often requires, essentially an epistemic analysis, going back to look and say, here is the knowledge that I'm relying upon for this, and here's how I'm valuing that, and here's how I'm weighting that, because there may be conflicting pieces or different understanding when I look at the clinical research compared to my experience, for instance, and how am I going to weight those things when I'm making this decision? I think if we're going to train people to be good clinical reasoners, we should be able to make that reasoning explicit, and epistemology, understanding epistemology, I think is crucial to that.
That's great, because we have a good clinical reasoner here, Nabila Mayab. She's my co-host today, and she's a final year medical student at Barts and the London School of Medicine and Dentistry. And she also has a Bachelor of Science in Medical Education. And Nabila, as I understand it, you try to work towards professional identity formation in any conversation, any chance you get, right? So have you found any connection yet between the topic of this article and professional identity formation?
Why have I not thought about that yet?
Okay, we'll get to that.
To be honest, I think the epistemology, just the whole thing is just, I think the way that I think about it is in the sense that I link it to myself and my own journey through my placements, in the sense that when I read this paper and I was learning about, I was reading about epistemology and experiential knowledge, I was thinking about how I've changed through medical school in the sense of the kind of knowledge I look for. And I've noticed how right at the beginning of medical school, I used to look for very what is in the books and very things to a point. And I used to get confused because you'd have different clinicians doing the same clinical examination in different methods. And I'd be like, someone just tell me the right answer. How do I get there? Whereas now I'm the complete opposite. Now, I don't want you to tell me what's in the book. If I can get it on Google or in a book, I don't want to know, because I can just do that myself. What I look out for now is experiential knowledge, where I'll be looking at the doctor and I'll be like, what's going through your head? And why have you chosen to do this and not this? And why do you like this medication and not this one where it does the same stuff? Things like that. But what I have found myself doing is over time, I'll start thinking, wait, how do I know if you're the right one or you're the right one? Because you prefer this one and you prefer this one. Who do I go for? And I think all of that sense of questioning and looking and analyzing different people's methods of down to how they act as a clinician, but also the decisions they make and the physical prescribing and things that they do, that I think all of that contributes to my identity. And therefore being aware of the epistemology of the knowledge I'm taking in and the things I'm learning and integrating into myself, I think is very important towards who I become in the future, which is hopefully a doctor. but yeah.
Mm. So that's interesting that you see the way you look at knowledge is part of kind of the person you are and your professional identity.
Part of my professional
yeah.
identity formation, so to say.
Great.
See, I brought it in.
Yes, you brought it in right at the start, and I'm sure you find 2 or 3 other opportunities. But yeah, let's discuss the article. Nabila, where shall we start?
I think what I want to ask first is, I understand you've explained this a little bit already, but how would you best describe the term epistemology, and why is it important that we look at it?
So as I mentioned earlier, epistemology translates to theory of knowledge or the study of knowledge. And while a hardcore epistemologist would say that if it's not good knowledge, it's not knowledge. But as a person who comes to philosophy of science, or epistemology from philosophy of science, I think that there's some more subtle questions to be asked about how firm a particular base of knowledge is, or how certain we can be about a particular fact. And in medicine in particular, how well we can count on knowledge to guide action. So I see epistemology as being, in this context, a way of thinking about the ways that people go about getting knowledge in clinical trials or in the lab or in the clinic. And when they know that that knowledge is actually secure enough that they can use it in different circumstances or consistently.
And what I found interesting there is when you said that if it's not good, like how hardcore epistemologists would say, if it's not good knowledge, it's not knowledge. I sense like a sense of debate there. So I was just wondering, like, where do you stand on that? Because to me, if it's not good knowledge, it's bad knowledge, which means it's still knowledge. And also, wouldn't it depend on who's asking?
I'm going to Plato now. This went meta really quickly, right? So the traditional view of knowledge in philosophy is that knowledge is justified true belief. So we have to believe something for it to be knowledge. We have to have good reasons or justification, and it has to be true. And I think that when we talk about specific things, like the wall behind me is yellow, it's a lot easier to figure out what it means to say that that's a true statement than it is when you're saying something like medication X is useful in condition Y for between 64 and 78% of patients. I mean, how do you map that onto something like the wall is yellow? And you know, if we're thinking about that, and then we think not just about the statement that medication X is good for condition Y, but also how we came to believe that. We may well have good justification, but we also know that it's true in sort of a provisional sense. So it's true that this is what this trial or these trials have found. We don't necessarily know how true it's going to be, or how this how much confidence we should have in using that medication in this particular patient. So truth, I think, gets a lot messier when you're not talking about simple statements, but you're talking about the results of really complex studies.
Right. And as a clinician, Mark, I feel like you'd navigate a lot of that sense of truth, especially when it comes to medication, and it works for this percentage of people. How do you find navigating that?
Yeah, and I think we'll probably talk about that more specific as we go forward. But I think one of the advantages that clinicians have is that they can appeal to sort of different types of knowledge, knowing that you know, anything that we're appealing to might not always be good, right? We'll talk about, you know, randomized controlled trials and the idea that that's best evidence, but sometimes that's difficult to apply to individual patients for a wide variety of reasons, right? You know, going from a study that demonstrates maybe something about causality to saying that we should be using a particular intervention for a particular patient is a huge leap. It's an epistemic leap. And so the good thing about being a clinician is you can appeal to other things as well, right? You can appeal to your experiential knowledge, right? You might be able to appeal to your own experiential knowledge as you develop clinical expertise, but you might also be able to appeal to that if some of your colleagues who are experts in particular areas. You can fall back on all that pathophysiologic, information that you acquired, that knowledge that you acquired in earlier in your training, and understanding how the body works and how it responds to different interventions. And you have to put all of that together to try to come up with what is the best course of action for a particular patient. And so, and both Robyn and I are gonna, have argued that there's not one type of knowledge that's always best. And that the case in any individual case, you may be appealing to multiple types of knowledge, and one type may be better in one case and not in another. So I do think that we should be able to then be as clinicians, and particularly as medical educators, able to say, this is how I'm processing this. These are the things that I'm appealing to. This is the knowledge that I'm appealing to, and this is how I'm weighing them differently. And when you brought up earlier, which clinician should you believe? You should be able to get them to be explicit about why they seem to be doing different things in a similar situation. One of my colleagues has always said, we don't disagree about the evidence, right? We generally disagree about, we might have different priors, right? How much we really believe the evidence is relevant in this situation. And we also weight evidence differently and knowledge differently. And so somebody may be relying more on their experience than they are relying on a clinical trial, and vice versa. So, but people should be able to make that explicit, and that's how we learn and how we teach, and I think how we become better clinicians.
You said earlier about being aware of what type of knowledge you're taking in. That reminds me of, if you've heard of that, do the thing where you have conscious competence, unconscious competence, like the 4 stages of learners, right? It's unconscious incompetence, conscious incompetence, conscious competence, and which one's left? Unconscious competence. So it reminded me of that in the sense that when we're taking in knowledge, especially like when we're taking it into our decision making and things like that, is it more important to be consciously competent of what we're taking in rather than the unconscious autopilot, just taking in knowledge and just taking it as is rather than questioning and thinking about it? Do you think that's a good way to think about this?
I think that there's, you're getting to an issue that comes up a lot, that in clinical practice, right? That there is some tacit understanding that's important for being a clinician, right? Where somebody says, I'm an ICU physician, and I say, that patient's dying, all right? And somebody says, why, how do you know that patient's dying? And I'm like, I've been doing this, that patient is dying, right? And if I can't tell you exactly why I'm conscious of that, I can at least say that I'm relying on this tacit understanding that I've developed over time. But I should, more often than not, be able to tell you, why I am making a particular clinical decision, what warrants I'm, bringing to bear, what knowledge I'm bringing to bear, and hopefully be able to explain that to you. I do think that it is a fine balance between, right, respecting the clinical expertise, and then this idea of that evidence-based medicine is always sort of railed against, the authoritarian clinician who does it. When you ask them why they do it that way, they say that's because that's the way I do it, right? And it's not. There is no explanation. And why are you, as the student or the registrar, going to be doing it? Because that's the way I do it. That's not a very compelling warrant for action, or it shouldn't be, right? So I do believe that that clinical expertise does often have this tacit element that comes from primary experiential knowledge, and it can be difficult to articulate. We should at least be able to articulate when we're relying on it. And then you or anybody else I'm working with can say, well, you're kind of lousy at this in the past. You told me that last person was dying, and they left the hospital a day later, or they can, you might be able to say, yes, I trust your judgment in this sense.
What I'm trying to figure out is whether your criticism of evidence-based medicine, actually that's what I'm trying to figure out. Is it a criticism of evidence-based medicine and how it deals with knowledge? Or is it kind of being critical about evidence-based medicine, but from the inside? The little I know about evidence-based medicine is the EBM triad. So you have the scientific evidence, the clinical expertise, and we talked about those two already. And then we have the patient's values. I worked at the GP vocational training, and there's a lot of emphasis there about how in a consultation with a patient, you're integrating these three different parts. So when I listen to that description of EBM, it kind of sounds like what you're saying as well, that there should be an integration between these three. I don't know if these are three different forms of knowledge, but they're at least three different sources of knowledge from your own expertise and experience as a clinician, from the scientific papers that you read, and from the person who's sitting in front of you. My question is your critique, or the critique that you think students should take to evidence-based medicine, is it from the inside or from the outside of EBM?
So I think it's both and, really, that, obviously I'm an outsider to evidence-based medicine as a philosopher, but at the same time, I think that all of the criticisms that I've made and that Mark have made have been very much constructive criticisms and intended to be helpful. I have in a couple of places described evidence-based medicine as being sort of akin to Churchill's defense of democracy. Democracy is the worst form of government ever, except for all the other ones that we've tried. And I think that's true of EBM. I think that, in its early days in particular, that EBM has really hooked onto a serious problem with medicine, that students were just being taught to do what they were told, to look at the right expert and do what they said, to go back to Nabila's point. But in terms of the triad, I think that EBM has also very much focused only on one portion of the triad, which is the clinical evidence. So, you see the hierarchy of evidence, which clearly says randomized controlled trials of treatments much better than physiological studies. And so they're being inconsistent in saying, well, of course, the physiological studies are an important part of the triad. We need to know pathophysiology, but also they're not as good as randomized trials. And then, similarly for clinical judgment, it ranks very low on the hierarchy of evidence, but it still comes in as part of the triad. And then the other thing is that EBM just says you have to integrate these things, but they're really not very good at saying how to do that. So Mark's work in particular has been really focused on thinking about how that actually gets done and trying to articulate it and make it explicit.
So there is something in EBM that clearly states you should integrate these, but exactly how to do that is still not clear.
I've given talks about these issues to clinicians for 20 years. And at the end of those talks, I've had clinicians come up to me and say, that's heresy. How can you be, how can you be attacking evidence-based medicine like that? And I've had other clinicians come up to me and say, that's evidence-based medicine. That's how I practice. I'm an evidence-based medicine practitioner, and you just described my practice. And I've gotten to the point where I frankly don't care whether it's evidence-based medicine or not. And I think, as Robyn said, it's both from within and from without. And I think that's what we need to help teach students is to not simply accept evidence-based medicine as the way to look at the world, but to be as skeptical about evidence-based medicine as evidence-based medicine is telling them to be skeptical about clinical research results, for instance. And then to, I do think helping evidence-based medicine with areas where it's not particularly good, and this description of integration, it simply leaves alone. It often just says you need to integrate this with your clinical expertise. And by the way, we're not going to really talk about what clinical expertise is. And you need to integrate it with the patient's, goals, values, and frankly, experience. But we're not going to really tell you exactly how to do that. We'll leave that to you. And I think we need to spend time talking about how that should happen.
one of the points that I really loved from the paper was the idea of being an evidence user versus being evidence-based. So if I think about it, that I'm an evidence user learning in the world of evidence-based medicine, and being a student in navigating the placement world, I feel like I'm turning into someone that's going to be an evidence user. And so I'll be one of these people who are taking on this knowledge and need to think properly about what knowledge to take on and what's good to take on for future patients. Would you be able to talk a bit more about that idea of being evidence-based versus an evidence user?
I think this is another real tension within evidence-based medicine as it was developed, especially in its early days. If you go back and you read the 1992 paper published in JAMA that introduced EBM, that was written by the EBM working group at McMaster University, they talk about a resident going to the library and finding studies and reading them and really thinking, how does this apply to my patient? Does this apply to my patient? And, if you read some of Ross Upsher's work about his time in medical school at McMaster, he talks about people challenging others to provide their evidence for decision. And there's this real sense that, you can get in and wallow in the evidence and really think about how it works. And then, not too long after that, the EBM folks started publishing things saying, well, it turns out that physicians in clinical practice don't have a lot of time to look at the evidence. They can't even keep up with, reading the abstracts of papers, much less digging into the weeds and going and doing library searches on their own. And not only that, but a lot of them don't want to. So this is where they make the distinction between an evidence-based practitioner and an evidence user. And an evidence user just takes summarized and pre-digested, what used to be called clinical pearls. I don't know if they use that terminology anymore. Now they're evidence-based clinical pearls, I guess. And they want what you said you wanted early in medical school. They want to know what the answer is, and then they want to use it in practice. But that's a long way from the other, really exciting in building skills in evidence assessment. And I think that tension is just always going to be there. I don't really know how to solve it, but at the very least, I think teaching students to realize that there's a tension and to know what kind of work goes into digesting and summarizing the evidence is incredibly important, even if they do just end up being off-the-shelf evidence users.
Yeah, I think about the idea of teaching students about this tension is very important and not something I have considered much. And even then, like, if I wasn't really into medical education, I don't think I ever would have considered it really, which is a really sad thought, really, to be honest. So when you were saying about and also that was in the intro to the paper about the idea of the introduction to the 1992 paper, of how a student's just sat in a library going through pages. I kind of just wish that I could still do that. I hate that everything's on the internet. I want to go into an old antique wooden library, go through papers and journals, which would be really fun.
It was really not fun. It wasn't fun, Nabila.
I would love it. Trust me, I would find it fun. With a candle on the side, a little lantern. But yeah, so that just gets me thinking about how I think one of the things that draws me towards, because we don't get to learn about this tension about evidence users versus evidence-based, that's one of the things that got me into identity in the first place, was the fact that I wasn't thinking about who I was becoming. And the fact that I had education to think about these things allowed me to wallow in that knowledge and think about, wait, what is actually going on here, rather than just becoming this doctor. And then you were saying about how thinking about how clinicians might not have the time to go through all the papers, but also some people just don't want to. And from all of this, I think it's really important to see that, it's really important to learn these things, and we can clearly see that. But if we do want to teach students epistemology better and this tension better, how can we make them enjoy it? Are there any ways that you think might be a good way to make students enjoy? Because I've had to think about this, and yeah, I'm always a bit how do you do this? It's hard.
Nabila, how was it in your medical training? Did you have anything about epistemology? And
yes, so we've had lectures, but this was back in the day where I'm ashamed at my past self, but back then I looked at it and I was like, what do you mean? How do we know what we know? Like, I don't care. I just know. Just let me live. And I found it very confusing. Back then, I just did not understand what it was on about. But I think also because I was a preclinical student at the time. And so I didn't value these things. I think once you become a clinical student, you value the difference in different types of knowledge and experiential knowledge and what you're taking in a lot more. So I think in terms of the challenge of teaching it, the challenge would be most present with preclinical students, because trust me, I was there and I am unrecognizable from who I am now, because back then I did not care, which is really bad. It's really sad, actually. But yeah, so I just don't get how we can teach it to preclinical students, because I think the key question when you're in medical school, you're in a state of fight or flight, and it's always just like, I need to stay in medical school, I need to not get chucked out, and I need to pass the exams. And it's always a case of, is it going to be on the exam, rather than, is this epistemologically relevant?
Yeah, and just to power on to that, because at the postgraduate, I work at the postgraduate training for GPs, and there it's a 3-year training. And there we've had talks about how to integrate more philosophy of science, epistemology. And one argument that I heard a lot there is that we should do that in the final year, because in the first year they're just busy with surviving, basically treating patients. And it seems that in your paper you're actually arguing the opposite. You're arguing that no, we should start with that right away. Am I correct in this? And how do we avoid that people don't see the relevance?
Yeah. So what I think we tried to argue for in that paper is that this isn't. We don't want to teach epistemology with one class, where everybody is their eyes are gonna glaze over and say what's going to be on the test, and and why is this of interest? But we recognize that different epistemic questions come up at different times in your medical training, and they're more relevant, right? So early on, when you're starting to learn a little bit about evidence-based medicine, I think it's important you can talk about what is evidence, what is evidence, and how does evidence-based medicine define it, and is that sufficient, and are there other ways you could think about it, right? So these are kind of just questions that come up when you're learning that. And when people start taking care of patients, other questions come up, right? And the integration problem really does tend to come up late. It comes up when people are in graduate medical education, where you're working with them, Mario, when it's this idea of, look, I learned all of this pathophysiology, I learned all of this science, I learned all of these studies, and now I don't know how to, I'm having trouble making somebody feel better. And how am I going to integrate that? And they're starting to develop some clinical expertise. And when do they trust their clinical expertise? And when can they? So I do think these specific questions come up at different times in medical education, and we can't try to silo this at one point. It's part of the process of developing your professional identity, right? So that over time, you're becoming a better medical reasoner with each step of the process, and you're understanding. You can go back as a clinician and say, oh, I'm going to go back and I'm going to really delve into this decision, and I'm going to do an epistemic analysis. I'm going to focus on what am I really appealing to when I'm making this decision, or why am I having a hard time with this decision, right? There's conflicting knowledge. I have differing warrants that seem to be in conflict. How am I going to resolve that? And if you have the basic understanding and some of the language, and even just the recognition that you're having an epistemic you're in an epistemic quandary, that will be helpful. So there's not one class that's going to do this, and there's not one seminar in graduate medical education that's going to be doing it. And I think a lot of it, for me, takes place on the wards when you're taking care of patients and you're in a group and trying to decide what you're going to do for a patient. being able to take a step back. And if we're disagreeing, why are we disagreeing?
That's really interesting because actually the reason I approached you for this series was because of your article that's called A Philosophical Approach to Addressing Uncertainty in Medical Education. I'll link it in the description. Because what attracted me there is that you make the argument that, well, what you just said, it's not just a separate class. Philosophy can be integrated in the curriculum in all different kinds of ways, and it doesn't have to take extra time. So that's a lot of times the reaction is that people do see the relevance of not just epistemology, but also of ethics and educational philosophy, perhaps. But where is the time? So that's what I find really attractive about your approach, is that if you only introduce it in the third year of postgraduate training, yes, then you need time because you need to start at the basics. And but if you do it just in little chunks, yeah, there's some really nice examples in the paper that you give on how to do that.
So I was just thinking, like, when you were talking about how we shouldn't just silo it off and it's something that we should develop over the years, I was thinking about how, well, I got thinking on a train thought of how are we teaching this, and how it would be great if we could just have sessions where it wasn't like, let's teach you about epistemology in a lecture. It was more like, how do we know this is true? And we're just literally just thinking and pondering, because I feel like we don't do that enough anymore. And that made me think about your children. And I don't know if I'm going completely on the wrong track here, but when you have a child and they ask, why is the sky blue? And you're like, because it is. And then they're like, but how do you know? And they're like, because. And they're like, but why? Isn't that at its heart sort of epistemology? And then I feel like what happens is, and you reach a point where you're like, because I'm telling you it's blue. And it's kind of like when we're growing up in society, I feel like I'm going on a complete tangent here, but I feel like when we grow up in society nowadays, it's so much a case of, but what's the right answer? But what's on the exam? But what's this? And we're kind of doing away with that sense of wonder and just thinking, but how can it be that the sky is blue? And how is my blue the same as your blue? And what are rainbows and all of these things? Yeah, I think my point is we can teach it. We can teach it at preclinical. It's just how you teach it, because kids themselves are doing it naturally. So that means we can definitely teach it at preclinical. But how are you going to get people to think? That's the important thing. And how do we engage people and, get them to really question things and get interested? I think you can teach anything as long as you just do it the right way and get people interested. That's all that matters. So yeah, that's where my thought train led me to.
So it's funny because everything that you folks are saying, it's so true to my experience teaching undergraduates who want to go into medical school. They know it's competitive, they know it's difficult, they want to get the good grades, they're willing to work hard, but they're a little bit afraid to ask the difficult questions or go off on an interesting train of thought. And so maybe the thing to do is start thinking about how undergraduate medical education might be useful so that they have a foundation of questioning and realizing that knowledge just doesn't get taken off of a shelf somewhere and applied, that it has a history, and that, the things that you learn in textbooks are not, the things at the time, those might have been really controversial and, contested discoveries. And, having, I think, some sense that that is the case even before they get to medical school can only be good. In much the same way that, a lot of places will require that students have taken a medical ethics course before they start medical school. Maybe they should also be taking philosophy of science.
In epistemology, there's something else that at least I've experienced is, I would say, summarize it as humility. Because in whatever context it is, if you start to think about how do I actually know this, you start to become humble as well about making grand claims of certainty and beyond medicine, just being more aware that, well, it ain't necessarily so.
Yeah, and there are philosophers and medicine who have emphasized that maybe one of the skills of, or one of the goals of clinical training should be to imbue clinicians with some epistemic humility, right? And that epistemic humility is a positive value for medical practice. And I do think that that's, and again, this is one of those things that may run counter a little bit to a simplistic view of evidence-based medicine, right? Where there's this idea of, well, here's the randomized controlled trial, so that dictates care. And often people are clinging to that because it seems certain and it seems true, right, with the capital T, because they've been led to believe that that's the case. And it does take some examination to show why that's, why that bit of knowledge, and it's usually a bit of knowledge that comes out of a clinical research trial, is only part of the issue, and that it may not be reliable as you think it is, and it may not be as true with a capital T as you think it is, and learning that humility. And I actually, going back to making this interesting for people, I actually think, largely in medical school, we're working with very smart people. The students are very bright, and these questions often come to them independently. We don't have to raise them. And sometimes it's taking advantage of that opportunity where these questions are coming up, right? When people are starting to think about it. I do agree with, I think, Robyn's implication. In general, I'm biased towards people who enter medical school with a background in the humanities, as opposed to in science. I do think sometimes it's a little more challenging with people who are coming from some of the hard sciences, who there's a sense that there should be a right answer, and there should be certainty, and that just doesn't exist in clinical medicine. And so sometimes it's disabusing people of that notion that there's knowledge in medicine that's certain, or that there's or that is always easily applicable. But there are plenty of opportunities that pop up.
So in terms of the opportunities that pop up, I was thinking, so if I went onto the wards one day and I thought, I read a guideline on something and I was on the wards and the doctor did it another way, and I'd be like, and they say, and I'm just looking at him in confusion, like, what are you doing? The guidelines are saying it like this. Obviously, I wouldn't say anything, but
you should. You should. You should say something.
I wouldn't though. I just sit and stay silent in the corner and hide. But if the doctors are saying, like, we are doing it differently here, how would you deal with that situation, and how would you how do you deal with that idea of, like, this is the way we do it, and when someone else has a right answer and it's like there's that mismatch there?
So I look at that as an opportunity to do an epistemic analysis, right, where somebody holds a paper and says, but this paper suggests, or they will say, this paper says we should do X with this patient. And I say, well, we're not going to do that, but here's why. And I know about the paper. Well, maybe every once in a while somebody hands me a paper I've never seen, and I'll go, well, let me read that, because maybe that will change my approach here. It's a new bit of knowledge that I now need to incorporate. But it's usually that it's not usually ignorance of the knowledge that's the difference, right? So then it raises the question for, why am I doing this? And in some cases it may just be, well, that's the way I do it. And that's a lousy epistemic, that's a lousy reason to do something, right? It's a weak warrant. It's a weak warrant to say, well, we should do something. But I might say, well, in my experience, or here are some things about this patient's physiology. This happens to me all the time in the ICU, where somebody is saying, well, this paper says we should ventilate a person a certain way. And I say, well, we're not going to do that in this case, but here's why: because their physiology is different. They're not tolerating that. They're having a complication of that approach. I can see that that's going to be an issue. But I should be able to explain that to maybe not always to somebody's satisfaction, but at least so that we understand why we're doing it differently. And I would go back to what you said about you would sit in the corner and not ask that question. I think we need a system of medical education where you should always be able to ask that question. And in fact, you should be strongly encouraged to ask that question, because that's the only way that we can teach this kind of reasoning. If otherwise, it just seems like it's my authority. And as Robyn was talking about earlier, one of the problems with being an evidence-based practitioner, right, is that you start to rely on somebody else's, or user, is that you start to rely on some other authority to tell you what to do. And you should, if you're going to do that, either rely on my authority because of my expertise, or the authority of UpToDate, or the Cochrane collaboration, then you should be realizing what you're doing. And I personally believe that, yeah, all students, and I strongly encourage it in my residents and fellows, like, if you don't understand why I'm doing something, you have to ask. And I will never take that as a personal affront. And I think one of the reasons you may learn not to ask that questions is that some people, some physicians who should know better, will answer, because that's the way I do it, and see that question as a challenge. That question is not a challenge to one's authority, or it shouldn't be viewed that way. It's a question about teach me how you reason.
Yeah, I think that links to the uncertainty point, and how if we were all just a bit more aware that the world doesn't work in rights and wrongs, and actually it's just fluid between certainty and uncertainty, I think everyone would be a lot more open and a lot more not, this is my way and I don't care. Like you mentioned the question earlier about so how do you know this patient is dying? I've actually asked that to doctor before, and in my head I was like, oh god, I'm gonna get telling off. But actually he was like, no, I know this because this, and it was one of the best things ever. And now I always think about it, because I'm like, how can I tell if a person, because it's, you think you can tell when someone's dying, but no, you can't. I think you can, but also in my head I'm like, how do you know? Because they're like, oh yeah, they're dying. I'm like, I don't understand. So Mark, when I was listening earlier, you were saying about how so you were talking about patients on the ventilator and how you can put them on their front to help them breathe and things, and how we have so much uncertainty. Now my brain put those 2 points together to remind me of something that I was reading around. So on Twitter, because all I do with a lot of my life is just scroll on Twitter and look at what all the random doctors say about their practice. And I remember when COVID first happened, it was such an uncertain situation. Everything was, no one could explain anything, no one knew what was going on, and everyone was just trying different tips. And what I noticed as like a side spectator scrolling through this Twitter was that actually Twitter's quite cool because you get to be like a fly on the wall. But what I was noticing was that a lot of doctors were talking about, oh, we've tried this at our hospital, and we've tried this at our hospital, you try this, you should try this. And people were just taking each other's ideas because everything was uncertain and we didn't know what was right and wrong. And one of the things that came up were, in terms of some people saying, actually put patients prone on the front because that helps them breathe. And then someone else saying, oh, but how do we know that works? And all of this to me, it reminds me of epistemology. And the thing is, so having to rely on anecdotal evidence in such a uncertain situation, do you think it would have been good for everyone to have been educated and know about epistemology in that situation?
Yes, it's interesting that you bring up COVID, because it is quite relevant to many of these discussions. And I was I don't know if you recall, but Seattle was the first community outbreak of COVID in the United States. And so we had all of the first hospitalizations in our region. And while I was taking care of critically ill patients, it was also quite interesting to observe how we were taking care of those patients. And frankly, there was a huge amount of variability in practice, even in our own institution, between physicians and within the community. And I do think the short answer to your question is it probably would have been better if people understood a little more about epistemology, so we could at least understand why our practices were so variable. And there's a lot of problems with having that much variability in practice. It's also important to recognize epistemology is not everything, because a huge amount of the variability was based on psychology. I'm convinced it was the psychology of the clinician. There were clinicians who simply could not do something, right? So the idea that they had this new illness with very critically ill patients, and we need to do something like different than what we usually do with critically ill patients with a viral pneumonia, which is take care of them, it's just support them. And so putting aside the psychological ramifications, there was a huge amount, there was this very interesting epistemic process going on. A lot of people were arguing from physiology, right? This physiology, the patient's physiology, things like hydroxychloroquine were arguments from, how the drug behaved with the virus in tissue. samples, right? And so there was a lot of pathophysiologic reasoning going on. A lot of it was really terrible. So this is another argument for trying to get people to be better at other aspects of using medical knowledge beyond just looking at clinical research. We should be better at reasoning from physiology when we need to use it. And then your point too about it was sort of this unsystematic, in an evidence-based medicine world, would be called unsystematic clinical experience, right? Which is at the very bottom of every hierarchy. And yet it's what we had. There's about 30 of us in the Greater Puget Sound region, all on a text thread, telling each other what we were seeing and what we were doing and trying to make sense of what was going on around us. It was very useful and extremely powerful, to be hearing from, the first medical center to feel this onslaught. Frankly, relying on published literature was really difficult. There was some published literature out of China where we looked at mortality rate. It's obviously a question like, what's the likelihood of surviving if you end up on mechanical ventilation with this disease? And the published literature out of China said it was 10%. And so we were, there was a lot of people wondering, should we be putting anybody on the ventilator if the survival's 10%, and particularly older patients or those who had medical comorbidities. But then when we're all talking to each other, it became clear after several weeks that people were coming off the ventilator, and it wasn't going to be 10%. And we didn't know right away what that percent was going to be, but we knew it was better than 10, and it changed the way we practice. And so, yes, there was a tremendous amount of value to unsystematic clinical experience and to pathophysiologic reasoning. And there were people who did it better than other people. And we learned as a community, we could hash some of this out amongst one another. There was also a lot of analogic reasoning or reasoning by analogy, which was, is this different than another viral illness that causes ARDS or not? There's this idea of COVID exceptionalism, like somehow it was fundamentally different than somebody with bad influenza or adenovirus, pneumonia. And it was really not. And so there was a lot of those discussions were going on as well. It was fascinating from an epistemic standpoint. It was also fascinating from a psychological standpoint, that some of my most, I would say, ardent evidence-based medicine colleagues were doing crazy stuff. Yeah, I mean, we're more than willing to cling to, a lousy study, a case report, or just so that we could do something. The idea that we could do something. So I think it's fascinating. I know there are people who are doing research on how clinicians behave during this period of time. I'm really looking forward to some of it coming out. And I do think it'll be interesting to look at it from an epistemic standpoint and from a psychological standpoint. Those are two different things. I would like to think that it was all an epistemic argument about what knowledge we could use, but it wasn't all that.
I would add to the epistemic and the psychological that there's also an ethical aspect to this. So, feeling like you need to do something is, very much an ethical position as well as a psychological one. There was a story in the New York Times a few months ago that looked at some of these issues, and they do a really nice job of sketching out some of the frontline experiences and some of the arguments that people were having about in particular, putting people into clinical trials versus doing whatever you could for the patient.
So listening to your experiences over COVID and thinking about how people were sort of working through the knowledge that they'd heard through analogies and read through pathophysiological reasoning, it would have been really useful to have the skills to be able to do an epistemological analysis at the time and to be able to take in that information and think about what you're taking in. So from people who have been listening and for people who resonated with that experience of COVID and just in general, and who are now excited about, how can I sort of bring this into my life? What would you say is one step that people can take from now to put them on that path towards thinking more about epistemology?
So I think, Nabila, one of the things that you said earlier about the toddler who keeps asking why, I think just the attitude behind that, you know, if something is presented to you as being something we know or something we should be doing in that situation, don't be afraid to ask why, you know, that this is supposed to be the thing to do. Or, you know, when given a piece of knowledge, like from a study, whether it's a clinical trial or a physiological study, just remember that the researchers who came up with this made a whole lot of decisions that went into the methods for that produced that result. And knowing that that's the case and asking why they made certain kinds of decisions is going to be really important, I think. So for just one simple example, the decision in a clinical trial of which kinds of patients to include. Do you include older patients? Do you include patients with comorbidities? The reason that there's a tendency to not include older patients or patients with comorbidities is it's easier to get an answer that seems very precise. But then there are other reasons for actually including them. And so not being hesitant to question the methods, not necessarily with the goal of critiquing them or showing that they're wrong, but with the goal of showing that they actually did shape the results in some pretty important ways, I think is a really useful thing to realize is important.
So those are some examples of what you call in the paper epistemic analysis. What can someone do to practice that?
So I think, like many things in medical education, one of the most, we're talking about how to introduce students to these concepts and learners to these concepts, but you need faculty, right? People on the medical education side to feel comfortable teaching this, right? And I don't know that we've, you know, in some ways, this is like a new technology where sometimes the challenges are that the learners master it before the teachers do. So I do think part of this is emphasizing with medical educators the importance of being able to explain your clinical reasoning and to focus on, you know, what you're appealing to, you know. And we talk about knowledge. Stephen Toulmin's a philosopher who has a method of argument that fits very much with clinical reasoning that, you know, talks about warrants, like, why are we doing this? Well, I'm giving this beta blocker because beta blockers are good for people with myocardial infarction. How do you know that? I know that because I have this paper, you know, that tells me this, and we can look at it in more detail. Or you could say, well, I know that because, you know, your attending told you that last week and you somehow believe them, right? You know, you like her and she seems to know what she's talking about. So those are different backings for that warrant, right? But being able to have this kind of discussion and this willingness, like, nobody should be like Nabila, feeling like they can't bring up these questions when they come up, and then being able to sort of walk people through this process. And I think the way you make it interesting to people is that you bring it up when they're interested in it, right? It's one thing to sit down in a class and try to teach people how to do this process. It's another thing to say, let's take advantage of this opportunity and discuss what knowledge we're relying upon here to come to this decision. And being willing to do that. As you probably know, like, you know, everybody in medical education knows that sometimes if you want students to know that you're teaching them, particularly residents or, you know, trainees in graduate medical education, sometimes you need to go, oh, we're going to take a moment and do some teaching, right? You have to frame it, because otherwise you just taught for 10 minutes and they didn't know they were, you know, when they say, were you taught anything? You're like, no, they never taught me a damn thing. So I think sometimes it's important to just be able to say it the same way. Well, let's stop and let's look at this. You know, I can see that people disagree or we're having a conversation about what the right thing to do is. Let's see if we can break this down more formally. What are you relying on, you know, to come to your conclusion? Oh, that paper. Well, I know that paper, so we'll talk about that. But what are, you know, is somebody else relying on? Oh, experience. How much experience do you actually have with this disease, right? So and calling it out and saying, we're going to do this now. It doesn't take long, you know, doing rounds. It doesn't have to be, you know, a half hour on a whiteboard. It can be, you know, 2 minutes at the bedside, and then we at least understand, how we're weighting knowledge and whether or not, again, somebody is just unaware of a particular study or some other bit of knowledge. So, but we have to encourage our medical educators to be comfortable doing that.
So it has to become a habit, if I hear you correctly.
I think it's a good educational habit. Yes. If you want to teach clinical reasoning, then you have to stop and make your reasoning explicit.
We need more blue sky thinking and asking.
I was just saying, I think that was a great example. And, it is true that as Mario can probably attest, sometimes with the 3-year-old, you just get tired of them asking those questions. But I do think that that's our role, whether as a parent or as a medical educator, is to be as patient as possible and in trying to answer those questions. And we may get to a point where we just say, well, I don't know, right? We often do as parents. I don't know.
Well, why don't you know?
Yeah, and then that may be just it may be that that's unknowable, or it may be that you just identified something I don't know, and now we should try. Maybe let's go see if I can figure that out.
Mark and Robyn, thank you very much for having this conversation with us. And I understand that you are writing a book about this subject. What is it about?
It's I think a lot of what we talked about today is there as well, and the way we're really approaching it is trying to make epistemology relevant to medical practice. It's written for medical educators and for practicing clinicians, so it's not a work that is for philosophers of medicine only. And but bringing a lot of these issues that have been written about in the philosophy of medicine and that are very relevant to clinical practice into a form that people can understand and will hopefully improve both medical education and clinical care, or at least make it a little more understandable.
Great. And thank you, Nabila, for co-hosting this with me. And thank you for listening. And next time we're going to talk about something that actually we've been using it the whole time in this episode.
Blue sky thinking.
We're going to talk about language.
Oh, okay.